Today we're going to talk about migraines. We're going to talk about what to do when the medications and the Botox stop working. And probably even more so, we're talking to patients who just simply aren't interested in taking the medications that are available for migraine in the first place, if they can avoid it, and if they have the type of a migraine that can respond to the types of things that would replace these medications. I'm Martin Rutherford. I am a board certified, or he's board certified. I'm a certified functional medicine practitioner. I'm a board certified chiropractor.
Dr. Randall Gates, I'm board certified chiropractic neurologist, also a chiropractor.
Yeah, so we're going to talk about migraines. We've done a migraine presentation in the past, quite some time ago. Dr. Gates wanted to update that, and I think justifiably so. Migraines are kind of a funny one for this office, in the sense that the board certified functional neurology field kind of cut their teeth on dizziness, vertigo, balance, migraines, concussions. But I mean, coming in the door, Dr. Gates and his affiliates in that field were well schooled in migraines. So logically, we at the time did talks on migraines. We actually did presentations, and lots of people came. Not a lot of people really started care from those talks, which was a little surprising, because migraines, to me, for those of you who've watched, I've had just about everything that we treat in this office. Fortunately, some of the things I have not had are migraines, dizziness, or vertigo, because when you as a migraine sufferer are sitting in front of me and I'm taking a history, I feel so bad for you, especially if you're going through a migraine, because the suffering just seems like it is so like focused and just disabling and so on and so forth. Yet there are medications that are fairly effective for migraines in their way.
Right.
And so what the reason I say that the migraine patients are a little interesting in this office is a lot of the things people come in here for, there without question is no silver bullet. I mean, if you have fibromyalgia, trust me, it's not about just a diet. It's not about just taking, one thing. And the same goes for just about everything else that comes in here. But migraines, you can take a medication, and many people do very well with that. So it becomes more of a, do I want to go through all the problems, all the trouble, perceived challenge would be a more PC word, okay? Through all the challenge of changing my diet and doing brain exercises and these types of things and get my migraine under control, or do I just pop this pill? Or do I just take a Botox? So we kind of have a little challenge in titling this one. So for those of you who may have taken the Imitrex and so on and so forth, or done the Botox and it's not working, this will be for you. Those people who just don't want to go that route, this will be for you. And there are people who go that route. And so that's kind of what we run into. The patient, we do a consult, find out what's going on with the patient, realize they would be a good candidate for this. And then the patient has to say, whoa, well, if I have to do that, I'd rather do this. And I think you'll bring some clarity to that. Because Dr. Gates is not going to tell you not to take the medication if it's working. At least that's what he said before we started this.
Absolutely.
So migraines, I think that's kind of our experience with migraines. Do you have anything to add to that for the patient who is qualified and goes into the program? Do most of them stay with that program? Do you have people that...
They do, and I think you prefaced it perfectly. Really, this is for patients who don't want to take medications, or this is for patients who have taken the medications and it's no longer working. Because the medications are a quote-unquote easier alternative for a lot of migraine sufferers, because some of these medications are very effective for a subset of the migraine patient population.
And if I were suffering the way the patients who have sat in front of me are suffering, and I want to get rid of it quick, I would probably concede to the medication. I would probably concede to the medication and do what Dr. Gates does. But I mean, because I get it. Believe me, I get it. It's just, it looks awful.
Yeah, so there's absolutely no judgment for anybody coming in here who does take medication. But again, a lot of our most intriguing migraine patients are the ones who have been everywhere. They've been to specialty centers, like Stanford, the Mayo Clinic. They've seen the headache specialists, and they're still not really responding. If you're not responding in that setting, if the Botox isn't working, you're constantly having to go in and get Toradol injections, then there are other factors in your physiology likely perpetuating the whole headache cycle. And so that's where we're going to kind of detail and elaborate on really what's causing your migraine, because if you can understand these different disparate pieces and how they fit together, you can understand where we're coming from a natural perspective, and how we start to attack each one of these factors. So starting with a migraine, in essence, think of dropping a rock in a pond. When you do that, you see the ripples spread out from where you drop the rock into the water. That's in essence what's happening in your brain when you start to have a migraine. And rather than, kind of the metaphor for the rock is inflammation in one part of your brain. And we all will develop inflammation in areas of the brain, but we should have the blood flow capacity to start flushing out the inflammatory mediators, as they're termed. Just think of it as like lactic acid. It's not really lactic acid to an entire degree, but think of it like lactic acid in a bicep that you keep doing a bicep curl with. Well, if you can't flush out these inflammatory mediators, then you start to have this what's termed spreading wave of depression. So it's called cortical spreading depression, where now it's almost like an earthquake with a shock wave spreading out from the epicenter.
And the cortex is all that stuff. When you see a brain model, all those corrugations in there, that's the cortex. So he's saying it spreads throughout.
Right. Yeah, it spreads from one area out from there. And then that is typically associated with your symptoms of, you may have the prodromal or the aura effect of a visual change. You may start to get light and sound sensitive, then the headache starts in, and you get the throbbing, the pulsatile features, associated features of you having to be in a dark room, stopping work, putting ice on your head, throwing up if you need to. These are all the clinical features or the symptomatic features of the headache. But what we're talking about right now are really the biochemical and physiological aspects of what's going on. Now, as I said before, with this area of inflammation, the first question is, why are we not flushing the inflammation out of there? Now, there have been studies looking at why the brainstem in a migraine patient maybe is not coordinating correct blood flow reflexes to the rest of the brain to get blood flow in there and flush out all of the waste, so to speak. So that's one aspect to the migraine physiology. Another is looking at glutamate. So glutamate is a neurochemical, it's a neurotransmitter as it's termed, and it's an excitatory neurotransmitter. Now, with anything in the brain, we need balance in these neurochemicals, and what they see in migraine patients is that glutamate can either be too high, so you may have too much glutamate in your brain, or you may have genetically different receptors for glutamate going on in your basically your brain substance. So with that, they started saying, okay, researchers started saying, why is glutamate too high in the brains of certain migraine sufferers? What they discovered is that there can be inflammatory pathways being activated in your brain, for example, that are not activated in people without migraines. And these inflammatory pathways involve the metabolism of tryptophan. So tryptophan is an amino acid we've talked about in other broadcasts relative to depression, but they're seeing the same phenomena being seen with migraine patients, dementia, and conditions such as schizophrenia. It's just basically, what are your genetics and what condition are you going to get? And so if you metabolize tryptophan down an abnormal biochemical pathway, rather than taking tryptophan and making melatonin and serotonin,
Which calms you down.
Right, you may make quinolinic acid, which is highly inflammatory, and it causes your brain's immune system and astrocytes, these are little reserves of glutamate and potassium, to start releasing glutamate, and that causes your glutamate to go up. And then that can be a reason why that this area of inflammation starts to become like a forest fire, so to speak, rather than just a little burning ember that your brain could flush away with blood flow. So that's another aspect to this. One thing,
is that related to seizures?
That whole process can be related to seizures, yeah.
Okay.
Mm-hmm.
I'm not the board certified functional neurologist. Sometimes I'm sitting here learning along with you, okay?
And we're all learning, so this is the up-to-date information.
The beauty of what we do, and I say this sincerely, is it's because we're in the alternative category in everybody's world and everybody's mind, is that in that field, there's such an evolution of what's going on. There's so much new data coming out that it forces you to stay up on things. It forces you to study. It forces you to understand new data, and then allows you to come up with new methods. And that's kind of exciting to me. It's a kind of a pain because my brain doesn't study as well as it used to, but it's really, so it is an evolution. When we say we're doing an update on migraines from just a couple of years ago, it's because a lot has, for example, the things that Dr. Gates was talking about, has evolved. And I'm always looking for those connections, like I said, because that sounds similar to what causes the seizures.
Right.
I was going to ask another question. All of the prodromes, all of the different symptoms that you said happened before that, is that because the inflammation hits at different parts of the cerebral cortex in different people, or different parts of the brainstem? You said how that inflammation. Right. So some people will get certain ones, and others because some will hit the occipital lobe and they'll have visual stuff. And
basically, it's where the inflammation is located.
I'm learning neurology as we speak. Okay.
And the cortical spreading depression is very analogous to a seizure, but it's a very slow spread, whereas a seizure is if you don't know what a seizure is, it's basically where your brain overexcites itself and your whole brain starts firing, or certain parts of your brain, like a whole hemisphere of your brain, starts firing. That can lead to motor activity. It can lead to typically loss of consciousness.
That come in with migraines.
Right. And so that's where, when they first discovered cortical spreading depression, they said it's very similar to a seizure, but it's not a seizure.
Okay.
If you get that.
And I didn't mean to subvert, but I wanted to bring out a concept that I think is important, that many of the things that you'll experience are related. And I'm always digging for that when I'm trying to understand somebody's history. So.
Absolutely. And so we have that element of the glutamate, the cortical spreading depression. Also, what's being talked about is just basically oxidative stress. So think of it as inflammation. There's inflammation at a higher rate in migraine patients than patients who don't have migraines. And that's another thought process as to why certain local blood flow reflexes are not happening. For example, like if you start exercising your bicep, your heart is going to pump more blood to get the lactic acid out of your bicep. But just also know that there are local factors in your bicep that are also trying to pump out the inflammatory mediators, trying to get more blood flow to that area. What they're finding in the brain of migraine sufferers is that you can have a lot of oxidative stress, a lot of inflammation there, and then that can be a perpetuating feature of your headaches. Going further, thyroid has been something that has always been tied, or long been tied, to headaches and migraine patients. If you read any textbook on migraines, the first thing they'll say to do is to make sure, A, they don't have a brain tumor. Second is make sure they don't have hypothyroidism that has gone undiagnosed. Because when your thyroid is low, it can basically predispose you to these migraine headaches. Now, there have been studies linking subclinical hypothyroidism with migraines as well, especially in the pediatric population. This is really important because you can go back and watch our whole broadcast on subclinical hypothyroidism. The nuts and bolts of it is that there's not exactly a universal agreement on when somebody should be treated for hypothyroidism. There's a blood test called TSH that is most commonly done when you have your thyroid checked. And basically know that TSH is inversely correlated to your thyroid function. What that simply means is TSH goes up, that means your thyroid is going down. So if your doctor says you have a high TSH, that means you have a low thyroid. And some doctors are trained to treat you for hypothyroidism when the TSH goes to 8. Others are trained to treat you when the TSH is at 5 or 6. Others are now in the literature, they're saying if it's above like 3 or 3.7, you probably need to be treated. And that's a very salient but important point, because if you have a TSH at 4 and your doctor may be saying, well, you don't really have a thyroid problem, so I'm not going to treat you, what you can do is go to powerhealthtalk.com to today's broadcast, scroll down the page of references that we have there. There is an article about subclinical hypothyroidism in migraine patients. You could show that to them and say, you know what, well, should I maybe be treated based on this evidence? Because you just can't hold your doctors accountable to all the evidence that's out there. You know, we're kind of like maniacs. We're always on the internet, on PubMed, trying to find the newest of the newest information, because as Dr. Rutherford said, we're in kind of a different field where we can maneuver quickly.
We can use it.
Whereas, you know,
they're very restricted.
Your doctors are restricted, and lots of times they're overworked, so they just may not be aware of these factors. So thyroid is very important.
Now, does that take into account that 85 to 95% of subclinical hypothyroid is Hashimoto's?
Well, and the research isn't quite focused on Hashimoto's yet. What I will say clinically, what we've seen, absolutely.
Yeah.
So
that's why I brought that up.
What we think is going on is that the reason why the thyroid problem is so important to the migraine is not only the thyroid hormones. Yes, thyroid hormones are important, but also the immune inflammation. So there are new studies tying the fact that migraine patients seem to have autoimmune issues, or there's a higher prevalence of autoimmunity, or different, what I should say is disimmunity. So there are just abnormal immune responses seen in migraine patients, and it's thought that maybe the immune inflammation is another trigger for the oxidative stress occurring in the brain of a migraine sufferer. Of course, we have to look at hormone levels. So migraines are much more common in women. It's approximately 20% of women have migraine headaches versus 5% of men. And lots of times these migraines are menstrual related. And so what we have to consider is that as a woman approaches menses, that's when her estrogen levels are at their lowest. And when estrogen levels are at their lowest, it can negatively, or I don't want to say negatively, but it can have an effect. And serotonin levels may fall as estrogen level declines. That can affect migraine headache phenomena as well. So that is basically the newest of the newest data. They're also looking at antihistamines. That's a new area of research. Most of you who have had migraines, you know that you may be put on Imitrex, or you may be put on Topamax, which is now Trokendi, which is the extended release form of it. If you fail those therapies, then maybe you're put on Fioricet. If that doesn't work, you know, you're going to the ER, they're going to give you basically Reglan, which is an anti-nausea medication, or prochlorperazine, or they may try an antihistamine. The antihistamine world is a new world in the migraine literature. Just know that. They're starting to use drugs in Europe that are antihistamines that are also calcium channel blockers. They're reporting good success, but they haven't been approved in the United States. But the bottom line is that their histamine is being associated with migraine phenomenology as well. Do you want to interject something?
I was going to ask, what about, I didn't realize you were going to go on to another potential cause. I was going to ask, what about, most patients that I interview seem to have a sympathetic dominant fight-flight mechanism.
I'm glad you brought that up.
That is, seems to be consistent with all of them. With Dr. Gates, and I mentioned the Hashimoto's, we're not saying here with saying, oh, you know, we thought of this like out of the clear blue. I mean, we've seen lots of patients, and so patterns start to come out in clinical practice. When I was practicing chiropractic, and I used to see certain things in low backs, and we were told it was one thing. Well, this can't be a muscle, and it turned out that after, like, you know, having 25 failed patients with their low back, being told that this finding on an X-ray couldn't be a muscle, and I'm looking at a muscle on an X-ray that they're telling me that you couldn't see. And then we started treating for that muscle, and they got better. Like 7 or 8 years later, we start hearing about the psoas spasm syndrome, you know. And it's not like you're a genius. It's just at some point you go, okay, this has got to be wrong. I'm doing what you told me to do, and it ain't working. And it's similar to this with Hashimoto's. We see it almost like all the time in these cases. And then similarly to the stress mechanisms, it's almost every single person that comes in here that seems to be a migraine sufferer, even if they're under control with the medication, seems to, even at their consult when we're sitting across the table from each other, have neurological signs that would indicate that they have this chronic fight-flight syndrome going on. Maybe you would know it as, I can't go to sleep. I wake up in the middle of the night. I can't get back up. Maybe you get anxiety a little bit for no reason at all. Maybe if you close your eyes gently, your eyes flutter. Things like that would indicate that that's there. So that's why I was asking.
Absolutely. So stress is linked to migraines. There's a more and more of an association being talked about in the literature. When you're under stress, basically blood flow parameters change, and that's probably why it's associated with migraine sufferers. Stress is not the singular cause, but it's an additive cause. So when you have the genetics for a migraine headache, when you have the hormonal characteristics, when you have Hashimoto's, and then you add stress into the mix, then absolutely, yes, we've seen that as a trigger, because it's going to vasoconstrict your arteries, or have a tendency to do that to the intracranial arteries, and that can affect flushing out. Think of the lactic acid in that one little area of your brain. You know, it's really interesting too, when Botox became all the new rave, so to speak, chiropractors have been treating migraine headaches for a long period of time, and massage therapists are reporting really, really good results with this. And for some reason, of course, you know, they were kind of poo-pooed and said, you know, that's not,
Well,
they're not really migraines.
You're cracking the neck.
Yeah,
How
exactly.
could
How
that do
does that
this?
affect it?
Yeah.
Well, what does Botox do? Botox basically changes muscular spasm in the neck and different muscles around the head. What we're finding is that muscle spasm, joint irritation can have a tremendous impact even on migraine headaches, even though we're not talking about cervicogenic headaches. So some people just have, not just, but they have a joint out of alignment, they have a muscle spasm in their neck, and that causes a certain type of headache that's separate from a migraine. But we're finding that the neck has tremendous impact on migraine headaches as well. And what you have to understand, we're working with a patient right now who has intense sensitivity to smells, and this person has horrible facial pain. And what we're doing is we're doing certain types of electrical stimulation. We're finding the right spots in her neck, and we're having some pretty exciting things happen, because in your neck, you have nerve cells. In your spinal cord of your neck, you have nerve cells that actually shut off pain from the head. And these nerve cells are stimulated by joint motion, think chiropractic adjustment. They're stimulated by stretch of muscles, and they're stimulated by electrical stimulation, basically. So that provides an opportunity to change head pain. And that's one thing that
acupuncture.
Acupuncture.
Probably acupuncture.
Yeah, and that's one thing that really made me kind of chuckle 4 or 5 years ago when Botox became this really almost like a fad phenomenon in the migraine world, and everybody's saying, oh, this is so great. But this was something that really had been applied on a similar level from a treatment standpoint by many other practitioners for decades with success.
Maybe a couple thousand years.
Yeah, or maybe a couple thousand years. Exactly, depending on the modality. I was thinking chiropractic in singular origin. So yeah, I think that pretty well covers it. We've addressed from Hashimoto's to stress to hormones to glutamate signaling to oxidative stress to autoimmunity. Those, and just know that there's all, you can go back and watch our other broadcasts, but autoimmunity has a strong basis in the gut and infections that are not being cleared from the body. And just know that the gut breaks down because many times people are under stress. Their brain isn't shutting off these stress responses, and that's why the gut breaks down. And you get this vicious cycle that then will manifest with whatever condition your genetics kind of predispose you to. So that may cause you to manifest as migraines, or it may cause another person to manifest as fibromyalgia and another individual peripheral neuropathy. But that's the singularity and the common thread, so to speak, we're finding amongst autoimmune diseases and chronic pain.
So if medications are working for you and you're happy, you know, we're good with that. The patient comes in here and they're on medication, but they want to get off. We don't, and we're not medical doctors. We work with their medical doctors. We don't advise them to have their medical doctor take them off the medication until the other physiology is working. You may not, those of you who've tried the medications and they didn't work may now have a better idea why, because one or usually a combination of these other conditions are present and are overcoming the medication's ability to work. And if you happen to be somebody who just simply is refractory to medication, just doesn't want to take it, there are other options that seem to be pretty consistently successful and can be teased out in a history and a real thorough neurological exam that evaluates these different aspects of what Dr. Gates was talking about. So I think that does it. And I think that was good. And I learned, I know what I need to put my hour and 10 minutes of studying onto this week. And yeah, that was good. That was good. I appreciate that myself, because I now understand it better. I didn't realize until you gave me this topic this morning that I had some real blind spots there. So I was looking forward to this.
Great.
All right.
Fantastic. And we'll see you next week with another interesting topic.